Welcome to the End in Mind Virtual Book Club. Relax on your couch or in your favorite chair, and we're going to listen to conversations about books that reflect what End in Mind is all about, and that is how to navigate life-limiting illnesses, caregiving to those who are seriously ill, walking the end-of-life journey, and life after a death. I'm Kathy Wurzer. I'm the founder of the End in Mind Project. I'm also a broadcast journalist with Minnesota Public Radio and Twin Cities PBS. We are in the downtown Minneapolis studios of Undertone Music, and we are here for a conversation with Dr. Luis Pagan Carlo. He's a cardiologist who's written a new book, brand new book, Your Life's Choice. It is good to have you here. Thanks for taking the time.
Thank you for having me.
You have been in medicine for a number of years. What led you to this field?
So I started life as an engineer, as I told you, and
That's a leap from engineering to medicine.
I was setting up cath labs for a company, and I was dealing with all the doctors, and I thought, well, why should I take orders from them? Maybe I want to join them. And that's how I went into medicine.
Cardiology specifically, you could have done anything, but you chose cardiology.
So cardiology, I actually liked many specialties in medicine. So because I was testing the waters in several disciplines, I liked many of the specialties in medicine, including surgery. But at the end, cardiology was the one area that I felt most comfortable with. It made more sense to me. It almost became a second nature field for me.
Do you remember the first time you worked on a patient who was in cardiac or respiratory arrest?
Yes. It was actually at the university here.
U of M, Minnesota.
At the U of M, right. And I was a second-year resident. It was my first night on call as a second-year resident, and there was a code call. And in those days, we had to sleep at Masonic and attend to the hospital, which are attached, but it's pretty distant. And running up the stairs, I lost my shoe. I went back, grabbed my shoe. I ran into the room where the patient was. She was in ventricular tachycardia, which is an abnormal rhythm of the heart. And in those days, they always recommended that you give a thump to see if we would break the ventricular tachycardia. I used my shoe and gave a thump, and she broke.
Wow. But what'd you learn about the process of trying to bring somebody back? I mean, seemed like it was fairly simple at the time, but subsequent cardiac arrests, I'm sure, probably weren't that easy.
No. And you know, in the setting of a cardiac arrest, many things are happening. Not only are people trying to figure out what happened, what's the cause of the problem. Sometimes it's easy. If it's a rhythm abnormality, you can tell pretty easy what to do, and then you just shock them. But sometimes you don't know. Sometimes you're dealing with an agonal rhythm, which means a deadly rhythm. So then you have to go through a protocolized set of orders to try to figure out what it is and try to rescue the patient. Mm-hmm. And that's actually what I ended up doing my research in, which was actually defibrillation. What
do you think the general public, doctor, doesn't understand about CPR? You know, you watch TV, everything looks so simple. They bring the patient back. And especially as we're talking about end-of-life wishes, care wishes, what doesn't the public understand about that?
That although the techniques are good and they work and they're shown scientifically to work, the numbers are not always that good.
Really?
If you have an out-of-hospital arrest, only about 13% of those patients live long enough to leave the hospital and go home.
Really?
And in the hospital is about 25%. And those numbers get worse as people get older.
Do you think those misconceptions are sometimes reflected in the written advanced care directives?
I don't think so. I mean, my impression is no. And I think the dramatization of medicine, i.e. the movies and TV, make it sound like everyone will get rescued and walk away.
Right, exactly.
Right? My favorite story is I remember maybe 15, 20 years ago seeing a movie that someone had a heart transplant. And I don't recall what movie it was. I don't remember if it was a TV movie or a big screen type movie. And at the end of the movie, the person who had just had a transplant within the last month was out playing football with his kids. And I kept thinking, that's never going to happen, at least not in the immediate future, right? Because we have been successful in medicine, and because there's been a lot of drama about medicine, people think the outcomes are always good, and they're not always good.
I'm wondering about advanced care directives, which, of course, your book outlines a number of different elements of making decisions that result in an advanced care directive. As a physician, how do you use a directive? How have you used them?
So I've used them a lot, and I've encouraged my patients a lot to use them. Remember that the Advanced Healthcare Directive is two things. It's basically a living will, which is a document that states what you want, and then the medical power of attorney, which is the person you have chosen to make those choices for you if you're not able to do it.
Right.
I mean, the big points that I think people have to choose is, at what point will I say no more to any of the techniques or any of the therapies? At what point is your quality of life suffered so much that you know that you're not going to enjoy whatever time you've left? That's a difficult thing for younger people to make, a decision to make.
Exactly.
Because no one walks in and, at my age group, I now feel things that I never did at 40, right? And I never felt at 30. I could probably still run a marathon, but I'm sure it would take me 3 years to recover from that, right? So you have to remember that as you get older, there are things that continually happen to you. A lot of them are very manageable. A lot of them are not. And then at some point, your quality of life suffers enough that you say, should I continue this? Mm-hmm. The best example I can give you is an elderly patient of mine who, avid reader, avid golfer. After his wife died, he basically never remarried, basically took care of his kids, his grandkids, and would spend his days golfing, playing horseshoe, playing bridge. He was a very active individual.
Sounds
he was
great.
A widower for 30 years. As he got older, he understood that physical activity was no longer much possible, so he picked up reading, and this guy would read a book or two every 3 days. I mean, the libraries knew him because, oh, here you are, Frank, right? And he would take a book out and bring it the next day. All of a sudden, his hearing and his vision are going. And with hearing aids, he had a hard time. Then cataract set in, and one eye went bad, right? At one point, he said to me, okay, I'm done. What do I do? And unfortunately, we can't do anything, but he was clear that any major disaster, he was never going to then treat again.
Mm. How old was he? Just curious.
He died in his late 80s, early 90s.
Okay. Do you run into people who, when you bring up, and I'm sure you've heard about this, when you start talking about advanced care directives, there's always someone who says, and I guess I did this myself, oh, it's too early. I feel fine, as you outlined. It's too early. But it's always too early until it's too late, right? And I'm wondering, it seems to me, maybe I'm curious to see what you think about this. I understand that advanced care directives are a needed tool in medicine, right? But I'm wondering, doesn't it seem to you that you need to jump over the hurdle of I'm going to die somewhere along the line to get someone to, before you even ask them to fill out an advanced care directive? There seems to be a conversation that needs to be had about just basically death and dying. And this is going to happen to you. Get your head wrapped around that and then fill out something like an advanced care directive. Does that make sense?
Yes, but I actually think that we live in a constant state of denial, particularly in the U.S.
Right.
Okay? Medicine has been very successful, and I'm a firm believer in what I do for a living. Okay? But the only two things that we know that are definites in our lives are taxes and death, right?
Right.
And, our fear of death makes us deny the obvious. There are still children dying in this country every year. There are overdoses of young people all the time. We're hearing about it. There was someone just recently who died of an overdose who fell off a third-floor story, a famous singer.
Right.
Young people die. Young people die either of self-imposed situations, accidents, or even conditions that they're born with, right? But as we get older, and I'm talking about past 40, past 50, the chances are that we are now looking at less life than more life, and people have to start thinking about it. So I think if you understand that you have to have a living an insurance policy in case something happens, so your kids have some money to study or to support until they find their new life, that's the time to start thinking, I may be mortal. And particularly cardiac disease, I mean, strong family histories in this country are declared in men in the 40s and women in the 50s. That means that there are still people in this country that have heart disease that die young that we're not even thinking about.
What other hurdles do you think that face people who drag their feet on thinking about some of these things?
So I think
you mentioned fear.
Fear of death.
Okay.
Lack of understanding. Lack of understanding of self, of what you live with and how you're going to live as you get older. And chances are that if you hit 60 or 70, you're going to have a similar lifestyle and probably a similar death to your parents, because the suddenness of a disease may have. I'm not communicating correctly. Sudden death is less likely as you get older as it is earlier in life, because most of the time, by the time you made it to 70, you've seen doctors. You're being treated. You're
for some
things,
chronic
right? Something is being
wrong.
caught up.
Yeah.
Right. So a sudden death is not likely unless you have a stroke, a clot in the lungs, or a massive heart attack. Other than that, few things will kill you other than an accident, right? So people see, well, my mom lived to be 90, I'm going to be 90. Not always, okay? Biology plays a role, and we all carry our parents' genes and our parents' strengths and weaknesses in ourselves. But we live in a time where there are exposures to many things. We are taught to ignore things. We are taught to not complain, right? So people have to realize that even in biology, there's something called apoptosis, which means it's programmed cell death. Cells die. And all you have to do is look at an old animal, an old pet, that leaves the nest at night. They start walking around the house crazy as they get older, or they want to escape. That's biology taking them out of the nest so that they get in danger and the life ends, right?
Right.
Older patients walk. If they get demented, they tend to leave the house.
Right. Sundowning.
Sundowning,
yeah.
right? So there are many biological processes that we consider just acting weird. When you stand back, you realize, wow, biology is really acting here, telling us it's time to move on.
Do you talk about this with patients? I mean, how do you even sit down with patients to open the conversation, especially those who might have an illness that continues to worsen?
So the hardest patient to talk to is a middle-aged man or a youngish man. Let me be perfectly honest. I would always want the wife to be there or the significant other to hear the conversation. Yes, I do have it. And I think the easiest way I would talk to them is think about it if we all lived in prehistoric times. A 45-year-old man is going to have a very hard time keeping up with a 17-year-old man. And the function was to hunt.
Right.
And to kill, right? So that man is going to have a hard time. He's now a burden to the tribe. A 40-year-old woman actually does a lot of the raising of the children because the mothers are now out there gathering. So, although this is my thought, this is not a scientific thought. As you become a burden to the tribe, you become less useful. And then somehow you have to be gotten rid of. Either biology gets rid of you or they leave you behind.
And you start conversations like this? Okay, what was the reaction on that one?
Well, but think about it. If you're a patient and you say, well, I'm too young. I'm like, well, think about it when you were before. Can you compete with a 17-year-old at hunting a tiger? And if you don't take care of yourself, because the key to longevity, in most senses, is to address the issues as they arise. And modern medicine is spectacular at dealing with the things that would normally kill you early on. Heart attacks, diabetes, hypertension, colon cancers, all that stuff that we do in medicine it's meant to get to the issues that are going to kill you early in life, right? And that success has made us think that we are going to be living for a very long time.
Right, exactly. And I'm wondering, when you open the conversation, what's the reaction from some of your patients?
Depends. Some people take it, some people don't. Some people, I remember an 85-year-old patient who was very upset because I was recommending blood pressure medications. They were beside themselves that they were taking a pill. I said, how many pills do you take? She says, none. I said, well, think about people that have been doing this since they were in their mid-20s. And there are people that have issues. So you have to put it all into context. People forget that we've had modern medicine, real modern medicine, since the 1960s. And you have hundreds of thousands of biology years before you got there. Before 1950, most people died of infectious diseases or accidents.
Right.
People grew up with kids dying of polio or infections and that kind of stuff. You talk to your parents, if they're in the 80s or 90s, some kids died of polio. Some kids never came to school after they had an influenza. We don't grow up in times like that anymore. Most of our kids graduate with us, that kind of stuff. So we've lost perspective of what normal biology is.
You have a mother who is older. I believe you said she's 89.
89 now.
So have you had these conversations with her?
Oh, we've had
does she have a
conversations.
vascular directive?
Oh, yeah.
Okay.
And we've had conversations actually throughout. I would even say before I was a doctor, we would have conversations like this about options and what we would want and what we wouldn't want. Obviously, when I was in my 20s, she was in her 40s, so it was not the same conversation. But as things started happening and she got older and I became a doctor, then it became a serious conversation. And recently, she had a significant medical event, and she said, "This is the last thing I'm recovering from. Next time you need to let me go. I've recovered enough. I have quality of life. But if I get to these points, no longer, please. Let nature take its course."
How'd you feel about that? How'd your family feel about that?
We're all very respectful. We all understand it.
Yeah, I'm sure. But there is that little pang.
Well,
okay.
Loss is loss.
Of course.
Okay?
Yeah.
But if my mother died at 90, it would be sad for the children and the few people that still know her, a few friends that she has left. But it's not a tragedy. And it's biology. Okay?
Yeah.
We all walk the same line. Okay? I think to be prepared is to understand what's coming. And there was a famous quote, and I can't remember who did it. It was from the 1800s, that said, if you've led a good life, a good death is part of what you're expecting.
Yes, right. Just so many people just cannot get their heads wrapped around that, though, sometimes.
Right.
It's just so very difficult. I was reading your book.
Yes.
And Chapter 9 addresses some of the conversations that you have to have in order for others to involved in your care to understand what you want. And you write about it is your responsibility to address this, not the responsibility of others to initiate the conversations. Interesting. So I wonder how to empower people to have these conversations. What's your best advice on that?
So I would say I'm not a firm believer in setting the tone, inviting the kids, going to the restaurant, having the right tone, the right everything. I think that's a daunting task. For you as a person trying to discover, right?
Yeah.
And for the kids to all of a sudden be confronted with, oh, that's talking about his death, what he wants us to do, right? Mm. I think it's best if you pepper your conversations throughout family gatherings. 5 minutes here, 2 minutes here, 3. Don't forget what I said last time, that kind of stuff. Because it becomes part of the normal conversation. As opposed to saying, I need to get this down, right? You can write it down. And maybe a check mark for yourself to say, I've addressed this, I've addressed this, I've addressed this, right? But I don't think a conversation for the receivers of your wishes is going to be easy, particularly if they love you. The kids are still losing a parent, right? They're losing a loved one. They're losing a resource they've had their entire life. So it's very difficult. But if you pepper it at a Thanksgiving dinner, 10 minutes and then move on to the next conversation, be it football or politics, so be it. But just pepper your wishes throughout 5, 10 years of conversations, and then ultimately choose your medical proxy of all those people who is going to be. Legally, if you don't choose a medical proxy, it falls on your spouse. If your spouse is comfortable, so that'd be the right person. But if the spouse is not comfortable, then you have to choose someone who will follow your wishes.
That is a big decision. That's hard.
And it started with a spouse. Some spouses want it, some spouses don't want it, and when you choose somebody else, they'll get upset at you because you'll say, you don't trust us. It's not a question of trust. I mean, you're making a decision about your end of life, and that person has to be accepting of your wishes and follow your wishes to the letter. And if what you have discussed is not exactly what's happening. They have to then draw from their experience of your conversations. He would probably go this way as opposed to this way, right? So it's a tough conversation, but I think if you, like I said, if you pepper it throughout decades of conversations or 5 years or so, I think it's a very doable thing. Many people have done it.
You know, do you run into people who say, are advanced care directives really followed when the rubber hits the road and something's going wrong?
Yeah.
Do doctors, do they look at that as guidance? Can they overrule an advanced care directive? Can somebody in the family say, "Oh, no, hang on"?
No. So if there's a clear document, okay, that says I do not accept intubation, I do not accept defibrillation, I do not accept IV medications, if it's that clear, they will follow it. There are doctors that may have problems with it, and then they have to refer you to another doctor to then manage your wishes, okay? But they are binding documents. I mean, the family could come after the doctor if they override things because the doctor doesn't agree with it, particularly if it's a malicious thing, right? I mean, you have to be careful. But, I mean, if the document is easily accessible,
which sometimes it is and sometimes it's not.
But if it is easily accessible and it's easy to read, they follow it. I mean, many times we would be called by a code and you would hear from the desk, "No, she's a DNR. Do not," and then we would back off.
Do not resuscitate, yes.
Then that would be it. People tend to, I mean, I would say 99% of the people in medicine care about these patients and want to do the right thing for them, okay? Sometimes because they are so hurried and under such stressors every day, it's hard for people to understand that they do care about them and they want to do the best thing for them, right? So if it's a document that's clearly written, I've told people, paste it on your refrigerator in case there's a 911 call, and if you make it to the hospital, put it on the wall. Have someone write DNR, DNI, even if you have the band. So there's someone knows what you want all the time, and it's available.
Do most doctors have an advanced care directive, do you know?
That I don't know.
Just curious.
I certainly do.
I mean, yes, because you know what can happen when it comes to, you know, the resuscitation process, as you outlined, doesn't work. It doesn't work all that well in terms of a long-term situation, it sounds like, right?
And really, in the palliative hospice world,
yeah,
the conversations are more important than the documents. Okay, so I tell people the absolutes you write down. The rest you can have conversations, right? If you are never going to accept dialysis, then that's one, you have to put that down. If you are never going to accept intubation, write that down. But people can say, look, I'll accept intubation for 14 days. If for 14 days I'm not getting better, there's no hope. I mean, really no hope. They're just dragging this out. It's time to pull, forgive the expression, pull the plug.
Yeah.
Right? That's a reasonable option. I'll say I personally would accept intubation for 2 weeks if it's a pneumonia or something else. But if I'm not getting any better, I'm not going to live with a trach in a machine. That's not likely. That's not quality of life for me, personally, right? So I wouldn't do it. The other interesting thing is there's lots of data that doctors die differently. They choose a lot less procedures.
I've seen that.
So we see a lot, and we understand what our limits are and what we're willing to do.
Glad you brought up hospice palliative care. I think most people don't quite understand the difference between hospice and palliative care. You know, hospice is obviously end-of-life care, and palliative, it's described as comfort care a lot, and that's true. But, you know, I've known people on palliative care for a really long time.
So palliative is actually, I think that the specialty itself is not well known. Right?
Exactly, yes.
It's a specialty just like cardiology, just like nephrology, just like dermatology. And if you have a condition that limits you significantly, but it's not killing you, you can go to a palliative doctor to make sure that the treatments that you're being offered give you quality of life and keep you comfortable. Palliative is not about the end of life. Hospice is about the end of life.
Yes, right.
And hospice means that you'll basically have 6 months left of life, with the exception of Jimmy Carter.
Right, exactly. I know. Wow. You know, actually, we have some questions from our audience, Facebook questions specifically. This is actually not on Facebook, it's from X. Bronco Bob. I don't know, Bob, I love Bronco Bob. I think that's a great handle, but Bob
Yes.
wants to know, when it comes to hospice care, who is responsible for raising the topic? Is it the doctor or the family of the patient? Do you have any ideas, any thoughts on
So
that?
ideally, we both. The ideal medical relationship is the doctor understands your wishes, you feel comfortable talking to them, and you say, it's time, right? For example, my mother feels comfortable saying to me, I'm done. I'm not doing this anymore. And if I can't talk to you, you need to understand when I'm done, right? That's my responsibility. And then I would communicate that directly to her doctors. Doctor to doctor saying, we're done, right? So you have to feel comfortable with your doctor. You have to, the doctor, the person who's at the head of your care, whether that be a specialist, or a primary care doctor, you have to be comfortable saying, look, I don't want this anymore. This is not what I was really planning. This is not, I feel so bad or I feel so uncomfortable. This is so costly. I just don't want to do this anymore. And costly, I'm talking about, emotionally,
Right.
Financially. The cost is an entire cost process. It's not just a monetary thing.
You run into people who, though, continue to want to go forward because they feel like if they give up, they're letting their family down. Have you run into that before?
That is true.
Yeah.
And that's because we live in a world where we're at war with a disease. The best answer I can give you is we all end up dead, right? And the meaning of life is because it ends. And you have to be comfortable with that notion. And dragging your pain and suffering longer ultimately does things to you on your way out as the patient, but it also has a big cost on the family. Once, and I don't mean to be flippant, but once the death occurs, the healing starts. The family restructures itself. Memories start coming back, right? I'm not advocating to do anything to yourself, but having control of how your story ends has a lot to do with how the family survives beyond you. Because if you've had time to say your goodbyes, if you've settled your accounts, if you've passed your wisdom, if you've played your dying role, what else is there? Just suffer all the way into the grave?
And of course, the flip side of that is you might have a family member who is wanting to hold on, and it's so hard to let go. Obviously,
but that's the family dynamics in this situation are always terrible.
Oh yeah.
Okay.
Yeah.
I've had issues within my own personal family. Okay, but that's grief. People are not thinking correctly in the middle of grief, right? That's why it's important to have the conversation. That's why it's important to have someone who will then stand up and say, absolutely not. He would have never accepted this, or she would have never have accepted this. We need to end this for her sake and for all our sakes. The best example I can give you, it's a personal example. My father had a terrible outcome after a major surgery. I had a sister who was very attached to him. My father and I was the youngest of the three children, but he and I became really good friends as I became an adult and he became an older man. So we were very good friends. We understood each other. We talked to each other openly, just like I do with my other friends, right? So I had a very good relationship with my father, but he died young. He died in his 60s. But he had been very clear what his wishes were. And my sister did not understand that. And after a couple of weeks of giving them a chance to realize this was not going to turn for the better, my mother once said to me, your father put you in charge of his decisions. You need to do the right thing for him. That was one night. That worked on me. I was a young man. I was in my 30s. Then my sister comes back and says, we're not doing this. I said, oh, yes, we are. I said, but I'll give you a little more time. I said, you go away for a week. Don't contact us. Don't hear anything that's happening. If when you come back, he is drastically better, and I mean drastically better, then I'll listen to you. If he is not, then the time has come. To her credit, she went away, stayed away for the entire week, came back and said, there's no change. I said, then the time has come.
And she was okay with that?
Yes. It takes, I mean, I will tell you that in my personal experience from my family, it took us about 5 years to come to terms with the loss and however, because what happens is that when a character in your family dies, there's a kind of restructuring around the family, right? And it takes about 5 years for that restructuring to settle out. Who's going to be, who are the voices that now, are important in the family, who are not, who are peripheral players. In 5 years, we all came back and said we did the right thing.
I know you're a fan of Dr. Atul Gawande, so am I. I'm a great admirer. And he says that our medical system inflicts unnecessary suffering on patients at the end of life. Not deliberately, but have you seen that?
Oh, all the time. All the time. Unfortunately, because patients are not prepared, and the family's not always prepared, they get lost in the fray. And doctors, in the limited time that we have to address these issues, if we're seeing a lot of conflict, we're not going to push the issue. So then you keep doing the procedures, you keep doing the medical therapies, fully understanding that they may not end up where they are, right? For example, there are patients that will absolutely not live in a nursing home, right? Guess what? Where they end up?
In a nursing home.
I had a very clear example not too long ago. A 95-year-old patient had a heart attack, and her kidneys were a little touchy. So we told her, look, if we do an angiogram, you may end up in dialysis. And she said, absolutely not. I saw my husband go through it. I absolutely will not do it. I will not do an angiogram. You can give me medications. I will deal with the medications, and you can put me on hospice if I need to. But I will absolutely not do dialysis. She didn't. Last I heard, she's still alive.
Really? Wow. Okay. I have a question from Lillian on Facebook. Thank you, Lillian. She wants to know, she's feeling that medical ethics or doctors have been trained to save life at all costs, right? She says, but what about the terminal cases and the balancing of quality of life at all costs in terms of how doctors, and maybe that's just a stereotype, but...
No, it's very hard. So, I mean, you've got to understand that we are trained to save life. We are trained to keep people alive and functioning as long as we can. And psychologically, it's a loss. It's a we've done something wrong and we don't accomplish, right? So I think if you meet younger doctors, they're more aggressive. As we get older, we start softening our edges. So I think in medicine, because it's been so successful, particularly in this country, we've lost sight of the obvious. And we don't train doctors well early on in life at how to step back and say, no more. And and I know that when you're young, you don't feel the same way as you do 20 years later.
It's so true.
And the doctors are young when they're coming out. They're feeling pretty well, right? When 40 years later, they don't feel quite the same. They've lived through, their families have lived through cycles. They've been softened as opposed to by their training. Their training is very produce, be good, save life, do this. This is the standard, right? Medicine is a spectrum. It's a gray spectrum.
I'm wondering, communication is so important, as we've been talking about, not only the communication that a person needs with their family as they're deciding what kind of care they want, but between their physician and their family. Right. This is a question again from Facebook. This is from Lisa, and she says, why is it that the majority of doctors won't talk about death with their patients or patients' families, even when it looks likely to them that the person is dying? And she had a sad situation. She said, we would have avoided unnecessary procedures with my mom if the hospitalists, the cardiologists, the neurosurgeons, and other staff were straight with us. It was almost as if they expected us, the non-medical people, to come in with the same base of knowledge they had spent years acquiring and making decisions based on that.
It's true. It's like that goes back to the same thing. It's the sense of failure and the fear of what that will bring. Okay, it's not an easy conversation. Hey, Kathy, by the way, the red lights are flashing. Right. It's a very difficult conversation. But I think that the family can say, is what you're offering me going to give her enough quality of life to live another year? Or are we saving her for another 3 months of and then repeated hospitalizations? Are we looking at quality of life that she will be able to get out of the wheelchair and walk by herself and be able to do what she did 6 months ago? Or are we talking about she's going to be in a wheelchair, probably in a nursing home bound, or will need total care? I think the family should feel empowered without being offensive. I mean, a lot of people get angry and then all of a sudden get offensive, right? Say to the doctor, look, this is not what she would have wanted. She has a terminal condition. We know she may live another 3 years with this, but is it going to be quality of life? A perfect anecdote. I had a good friend just call me. She bought the book and read it, and her sister needed help setting up her thing. So she used my book, and they set up the living will. Soon after the living will was set, the sister gets sick, and now they have to make a choice. Guess what they had? They had the sister's document. So people have to feel comfortable talking about this because we will all get there. You do it now for your parents. Guess what? Your children or your nieces and nephews are going to do it for you.
Right.
So you need to have the conversation intergenerationally and feel very comfortable about these topics.
You also need to know, too, just what does quality of life mean to you?
Right.
Right.
And that's very personal.
Exactly.
That's very personal.
Right.
One of the things that I say, I think I mentioned in the book, is some people, quality of life may be living on a ventilator in a facility, but seeing their family once or twice a week. That's enough. That's quality of life for them to want to live. So be it. That's your choice, right? But other people say, if I can't do this and this and this, I'm done. My quality of life is done. Then that's their choice.
I think I remember, actually, not to name drop, but I remember interviewing Dr. Atul Gawande. It was a great time. We had a great time. And his father said, if I can't eat chocolate ice cream and watch, I think, football or something like that, I'm out of here. Those are my two, yardsticks.
The two crossroads.
Exactly.
And I think, so people should choose based on quality of life. If you choose your markers of what you think is your quality of life, what you will not tolerate when they're gone, and that starts your clock. That's how you start thinking about these things.
So with your book, you have it's just packed with information. And I'm wondering, as you look at the situation of having these conversations in our society, and you talk about how to start them, how does one put this into action,
So ideally the book, I wrote it for doctors to give out to patients so they would have an idea before they made their choices, or estate planners. I think children can read the book with parents and ask the questions. As you know, the book has questions at the end of each chapter. Once you're done with all the chapters, or the 9 chapters, then you can transfer all those answers to the 10th chapter, which is kind of a workbook. There's a couple more questions, and now you have an outline of what your living will would be like. You can then take it to your doctor and say, let's make the documents, or to your attorney and say, let's make the documents. I would say there are people that are very versed in the topic, so they can just go quickly to the end of the book and figure out what they want. Some people may have to start from the beginning to understand the process. And I wrote the book so that they would understand how to start thinking about it, the statistics of it, survivabilities and that kind of stuff. And I included a couple of quotes from Atul Gawande, from other authors that talk about how effective these techniques are, right? And then we go straight to the crux. What is CPR? What is intubation? What is IV fluids? What is IV antibiotics? What's antiarrhythmics? And that's a full spectrum of things you can choose from. And I would say...
Really confusing, by the way.
People have to read them, and that's why I wrote it. So there's an index key points, and at the end there's a glossary. You can go back and say, what does this mean? That addresses what they questions, and they can always reach you or reach me,
Absolutely.
and I'll be happy to address any further questions that they have about what they're reading. Speaking
of questions, Wendy on Facebook says, my question for the cardiologist would be about who should be recognized in law as the authentic voice for a terminal patient. Is it the individual or the immediate caregivers, or much like today's policy debate about women's health law, a checkerboard of states making political decisions in the courts? Who's the authentic voice in this situation? I guess I would say the patient.
The patient is patient. This is all patient-centered, okay? And then the patient has to decide who is the right person to make the choices for them if they cannot, right?
Right.
That gets to be a little difficult, but the family has to get to the point and respect the choice, because they are asking this individual, whether it be the spouse, one of the children, a neighbor, a cousin, to make choices based on their conversations and respect their choices, difficult as they may be, right? And I am sure there are many situations where there's two family members that could fill the role. So one could be the primary, and in the absence of that person, then the other one would be the secondary. And you can choose based either on a flip of a coin, or this person seems to be more. Remember that emotions come into play when you're making these choices. And the thought of, I'm letting Dad die. Well, no, you're not letting Dad die. You're following Dad's wishes.
That's true.
Okay? Mm-hmm. And if you respect and love Dad, then you have to follow their wishes.
That is true. Although I have to be honest with you, I did find that to be, I was my father's proxy. And I thought to myself, oh boy, this is heavy stuff.
It is heavy stuff.
And when we got to the end and he was dying, we did follow his wishes, but it was
wrenching.
It was.
It was wrenching for me as a doctor.
Okay, I feel a little bit better then. Well,
But I mean, so to be perfectly honest, we're human beings too, right? I mean, what's happening to our relatives is going to happen to us. So it has many layers of fear, of loss, of anxiety, many layers personally. I will say that when you become, as you take care of patients for many years, they become friends. These are people that you care about, that you will take their phone calls. You also feel the loss, right? I mean, there is a loss there, but you have to think, what would they have done, and what were their wishes, and how am I serving them best, by keeping them around or following their wishes? So the conversations are key. The documents are secondary, but they should be filled because you need to have someone speak for you. You never know when all of a sudden you won't be able to talk.
Do you find some of this, though, difficult given, as you pointed out, the fast-paced, modern medical environment we find ourselves in, where doctors don't have, what is it, 15 minutes in the exam room, It's hard to have these relationships with your doctor.
Well, I think what's happened, part of the reason I wrote the book is when I was in practice, I used to see them in the clinic and in the hospital.
Right.
Now your primary doctors are in clinics, and you're seeing strangers in the hospital.
The hospitalists, yes, exactly.
So, and they mean well, and they're good doctors, and they're terrific people. Many of them are my friends, right? But they don't always know, so they need some guidance. That's the importance of the documents and the medical proxies. So I would say, have your primary doctor who knows you, who you follow, who you trust, help you guide, make your documents and your wishes. Make sure that they are legal for the state that you are in, because every state has different requirements, right? And you can find that out to the state attorney's websites. Once you have your documents, just make sure that all the facilities that you're likely to attend have them. These are all medical records everywhere. And have one attached to your refrigerator in case someone has to run and get it.
That's excellent. Getting back to another question here from the audience, Austin, thank you, from X, a question on X. How would you recommend a family member best comfort a loved one who's terminally ill yet still afraid to die? Do you have any thoughts on that? You've been at bedside.
That's very difficult.
It's really hard.
There are spiritual needs that have to happen. There are physical needs that have to happen. And there are psychological needs that have to happen. So the only example I can give you is I had a young friend who was dying. Mm-hmm. And she was one of these angels that come in life, right? That do everything right, that are wonderful, and all of a sudden they're taken away. And I had to say goodbye to her. And you could not lie. I felt very serious that I could not lie to her. And I had prepared myself. If she asked me, am I dying? I would say yes, right? So you have to be ready with the truth. But if they're not ready, don't push it on them. Just encourage them to think about their life, what they've learned in life, what they have, what wisdom they want to impart. In other words, help them play the dying role without them accepting it. At some point, they will. Most people come to terms with it. right? When they start seeing that it's inevitable. But I certainly would not push on them. It's not your responsibility as a family member to say, you're dying, enough of this, okay? If the doctors are not willing to do it, there's nurses, there's hospice, there's social workers that can help you get the message if it's absolutely necessary. Sometimes you have to play the role and just let it happen. And I'm not saying ignore the death, but help them play their dying role.
Austin, that was a good question. Thanks. I appreciate this. What spurs you on to do this work? I mean, you've been a cardiologist for a number of years. You've seen patients. Now you're getting into a different role in your life here, and it's interesting for me to listen to you.
I think so. I've always loved being a doctor. Okay, it is a privilege to take care of people, and people put their trust on you. They come to you, and when they're at their healthiest and sometimes at their weakest, and they say, "Here, take care of me." So that's a privilege that I've never taken lightly. Okay, but I also believed early on, and I think it was a psychiatrist in medical school that said, our responsibilities are to take care of these patients in health, and make their death palatable and acceptable.
Because we all meaningful.
And meaningful.
Yeah.
So I've always taken that role. I mean, you kept them alive and healthy as long as you could, and there's many things that we do that work very well. But there are times that things fail. We've all had that experience, right? And that biology takes over. Then it's time to say, okay, now how do we better serve this patient? I think palliative and hospice serve that role nowadays, but people are so afraid to use them that most people end up in hospice and die within 3 days.
That's true.
Right?
Yeah.
When they could have had 6 months of good quality of life. Because hospice is about quality of life for whatever time you've had. And I recommend anyone, to this day, if you're going to have a very aggressive procedure, whether it's a valve replacement, whether it's a kidney transplant, a heart, I think you should talk to palliative first.
Really?
As a specialty.
Interesting.
What are the options? What do I do? What happens? And what are my options if things go bad? Because then they will help the transition into a hospice situation without difficulty. That's their specialty.
I can see someone, if you brought that up, thinking, whoa, this is heavy stuff.
Well, but think about, so also, Keith, I'm primarily not dealing with a pediatric population, and I rarely see people in the 30s, to be perfectly honest, right? But by the time I'm seeing them, they've had many issues coming into life, right? People have to understand that there's a limit to what we can do in spite of all the advances. And despite the fact that I'm not saying that what we do doesn't work. It works great. Look how many people live with transplants. Look how many people live with valves and stents and bypasses. What we do is in many ways miraculous.
It is.
But there are no real miracles in the sense that no one's going to all of a sudden get out of a deathbed and all of a sudden live. They'll have a surge of energy, but once the end is near, it's coming, right? And people have to accept it. We have to accept our mortality. I personally think our lives are more meaningful if we live with the prospect that I may not be around in a week.
Do you live your life like that?
Yes,
Just curious.
actually think about it.
Yeah.
I've always told, I don't take risks. In other words, I don't go bungee jumping. I won't do that, right?
You don't seem like you would.
Primarily because I'm old and my back will go bad, and then guess what? I don't want to do that. But am I afraid of taking risks in life? Absolutely not. Why? Because there's a magic when there's change. There's a magic when you experience something new. I'm not afraid to travel. If I die during travel, so be it. I was learning something new. Right? It's an experience. Life is about living an experience. When you're dead, they're not going to be able to take away what you've experienced away. They'll take everything else, right?
Right.
But your memories and your experiences are with you. So, no, I think life is about living it. Life is about experiencing things. I'm not a firm believer of walking to the ledge of the Grand Canyon and taking a selfie. I think that is a ridiculous proposal, or climbing up that's not what I'm talking about. I'm thinking life is about experiencing and taking chances and expanding yourself.
I love that. How do you want to take what work you're doing right now with your book, Your Life's Choice? Where do you want this work to go? Where do you see it?
I think I would like this along with. There's a lot of people working in this field,
Tons.
and they're doing good work, right?
Yeah.
I think what we're missing is how do we get this conversation to a bigger level, to a societal level where in a way, we are speaking to the converted, right?
This is true. Yes.
Right?
Yeah.
So how do we speak to the non-converted? How do we become voices to take people from where they are that they don't want to hear this to where they at least are considering it? How do you become a leader and take people where they don't want to go, right? And it's not a morbid subject. I'm not talking about morbidity. I have a 90-year-old aunt who is taking care of her grandkids, and if you listen to her voice, she sounds like a 35-year-old, right? All the power to her. As long as she has quality life and she's able to do what she wants, go to it. I'm in support of that. But not all of us are going to get that chance. Our biology is the main, determinant of that. If you hit a certain age, it's your biology that takes over that. And at least by today's standards, anything above 80 is frosting on the cake.
Pretty much.
Right?
Yeah.
So you want to be, if you live to be 90, you want to be 90 in good shape that you have quality of life and then a rapid decline.
Do you see differences, by the way, as we're talking about how people view the end, differences culturally? Have you ran into them different in your practice?
It also has to do with a lot of religious beliefs. But what I've learned is
or
that...
lack thereof.
Or lack thereof, right.
Given nowadays, yeah.
Right. But so no traditional major religious faith, Judeo-Christian, Islam, is against a natural death. They don't talk about it. They don't prohibit a natural death, right? What you cannot do is take your life. But if you are having a condition that's going to terminate you, your end of life is happening. You're choosing how you want to end it comfortably or in your quality with your dignity, right? The end has been determined now. It's not you doing something to yourself. And before 1960, before 1900, guess what? There were not many options. People died at 50. The standard age, as I recall, in 1900 was around 49.
Right.
Right? So it's biology. It happens. We are all built-in programmed cell death, for lack of a better word, right? It's going to happen to all of us. It's just a question of how do you take control? Because I think technology and medicine have gone so far ahead of what our biology is able to handle that we don't know the limits. And that's where I think it's gotten lost. We have not been able to tell, when you operate on a 90-year-old, chances are they will do well, but chances are they won't. And it's almost a 50-50 proposition. In today's world, if you've had a large stroke, doing any kind of surgery on someone big or small, it's a dangerous proposition. They may not come out the same way, right? So people have everything that in medicine we talked about, the risk and benefits, there's a lot of science behind it. But that doesn't get transmitted directly to the patient in an understandable way. I understand it because I lived it and I worked it and I saw all the good and all the bad, right? And I think because technology has gone so far ahead of biology and how much we can do, it'll be another 50 years before we know the limits of what we're doing currently. Studies are coming out that certain drugs are good, but medicine is full of mishaps, and it's not because they want it to be mishaps. It's because they thought they were doing some good, but they weren't. We've heard of drugs that we put in the market, and all of a sudden we have to pull out, right? The scientific process takes years, and it takes hundreds of thousands of patients to really see the effects of the things that we do. And in 25 years, 30 years, we'll know if the therapies that we're using nowadays for 90-year-olds were truly effective.
What do you want to leave the final message here with our friends that are watching? What haven't I asked you that we should underscore here in our conversation?
I think it's the responsible thing for your family to address your wishes. and not be afraid of it, because we all end up in the same spot.
Are you pretty clear about your wishes?
Pretty much.
Pretty much.
I would like, I will tell you clearly what I think. I would like to be as healthy as I can with a rapid drop off.
I hope that for you.
Right.
But who knows?
Exactly. No one knows.
Right.
No one knows exactly. But to be perfectly honest, that's how I got rid of my fear of flying.
Oh, you were afraid to fly?
I was afraid to fly. I'm an engineer. Why would I be afraid to fly? For years,
I know.
And I've traveled the world. I mean, I have gone on planes for 16 hours, right? But it was grabbing the seat and looking at the engines the entire time, because I love to travel, right? But then one day it dawned on me as 30 seconds down and I make the papers. Big whoop to do. And nowadays, the plane starts shaking, and that is the best way for me to fall asleep.
Okay.
When they talk about turbulence, I think I would sleep right through it.
So to use your analogy then, you're
And keep in mind that it's the safest way to travel, easier than driving.
good to know. I'm not a big fan of flying, but okay. So are you saying that, go back here in terms of how you might view your end. So yes, I hope that it's I hope for your sake is you get to 90 and it's a rapid descent.
Right.
But it might not be, but are you prepared for that?
So I'm pretty clear that I will accept certain things, age appropriate, okay? For example, I think if someone offered me a valve replacement at 90, based on today's data, I probably wouldn't choose that right now. Okay. Dialysis, I always tell patients, try it. You can always say no. You can always try it. If you don't like how you feel, you don't like, the fact that you now become dependent on a machine, you can then pull out and say no. Respirators are harder because you lose control. So I would say I personally, and this is only applying to me, I'm not making this as a recommendation, I only would say 14 days. If in 14 days the doctor comes back to my proxy and says, not getting better, but we can give him another week, I'd say no. I'd say it's time to go. If I'm really bedridden, being bedridden is not the most comfortable thing to be, because as we all know, you lay in a position for a long time, you get sore.
Yeah.
And then bedridden means you get bed sores, which are very painful.
Very painful.
I don't want any of that, right? I'm not afraid of fasting if I have to fast. So if they withdrew fluids and all that, I would not be. I mean, as long as I kept my mucous membranes, moist, I would not be afraid of that.
Okay. You have this very well thought out.
I've thought about this my entire life.
Yeah.
Because I've had a lot of elderly patients and family members that are elderly who have asked me, how should I do this? Right? And then I would say, well, in these situations, I would choose this and try that for comfort or for extent. And they've worked out, they've been pretty, I mean, they've said thank you, so I presume it worked out pretty well.
Now, if people want information, where can they go?
So they can go to silvermangoes.com.
Silvermangoes.com. I got to ask you about silver mangoes.
It's a great story.
I love that.
It's a great story.
Okay.
Silver, my hair. Okay, old. Mangoes, my grandmother used to tell me as a euphemism, when I go to the mango grove, which meant when she went to the cemetery.
We're talking about Puerto Rico. Yeah.
The cemetery was near the mango groves. And she would say, when we go to the mango grove, she meant when I'm dead.
Oh.
So,
when I go to the mango.
Silver mangoes. That's where it comes from.
Okay. I love this story. That's great. Silvermangoes.com.
And for the book, they can go to yourlifeschoice.com directly. There's no apostrophe in lifes.
All right. And by the way, we have a link to his book on our website, and you received that link when you signed up for this conversation. So again, silvermangoes.com. I've really enjoyed our conversation.
Likewise.
Really. I've heard a lot about you. I'm glad we could sit here across from one another. Thank you so much, Doctor. We appreciate this.
Thank you.
Dr. Luis Pagan Carlo has been with us. Thank you for being with us, by the way. I appreciate your time. Keep in touch. We've got some other great things happening. You can check out our website. Sign up for the newsletter, by the way. We've got a good newsletter. endinmindproject.org. We'll see you again next time.